Okay, let's make a start. I think people tend to sort of trickle in over the next 10 minutes or so. So I think it's otherwise we're going to run out of time. So welcome everybody to the meeting. I think most of you heard me say, but Hazel's not with us today, so I'll be chairing the meeting in her place. And normally I know Hazel does a bit of a round robin introductions, but I'm not sure whether we have time to do that today. So there is a point on the agenda where the clinical cancer leads normally do an update. So if we could do introductions, then that would be great. Julie, have we had any apologies? Direct apologies to you.
I've not seen anything to myself, Kate, sorry.
That's okay, no worries. I just thought, here's a few more popping in now. Wasn't sure if you'd had any apologies in response to your email last week. Housekeeping, so I think normally we say if you can keep your camera on, that's great, but no worries if not, and everybody mute unless you want to ask a question. It just helps with interference, and just pop your hand up and we can or put it in the chat as well. That's absolutely fine as well. And then just notes and actions from the previous meeting. So Julie sent out some papers last week, and she sent out obviously the agenda and the action planner, but also the prostate cancer searches and suggested text for the AccuRx. I'm not sure if people want to comment now or whether they want to wait till their update, but it would be really good to hear any feedback on those searches and whether anybody's used them yet. Also prostate cancer awareness training, that was on the agenda last time, and as hopefully you've all seen, my colleague and my colleague Lisa and I have started that training now, and Lisa's going to update on that a little bit later on. And finally the FIT pilot as well, that has also started, and the PCNs that were involved were sent the relevant information, and that is also on the agenda for update today. So nothing further to update on any of those. Okay, so the first item on the agenda today is just a conversation really about data monitoring, and obviously we have our DES in place for the year, and myself and Hazel have sort of been talking really about how we personally as an ICB monitor the DES and how people are getting on with achieving the DES. This isn't about performance management really, it's about Hazel and I looking at how people are getting on and where we can offer support really. And I've just put a list of the suggested data which we are looking at collecting, and some of this we should be able to get directly via ARDENS and PCIT, and I'll talk about that on the next slide. But first of all, we're looking obviously at non-responders, that's still in the DES, looking at cervical and bowel screening, and just looking at the percentage of non-responders contacted. Obviously we've now got the IIF target in the new DES around the percentage of FIT requests accompanying lower GI referrals. Also percentage of 2-week rate referrals that are safety netted using the electronic template. There's Macmillan's and ARDENS, and also PCIT as well have an electronic template, and also just measuring the 2 QOF targets around supporting patients post-diagnosis. So this is about delivering the cancer care reviews, but also making contact with patients within 3 months of diagnosis. So those are the suggested data that we're suggesting that we collect, and obviously depending on what that data tells us, we can then go directly to PCNs and offer support where needed. And I'm just really opening it up to the group if anybody's got anything to add on that and whether people think this is a good idea. I'm conscious about asking individual GP practices or PCNs to provide this data. So we have started having some initial conversations with Primary Care IT and also the GP Federation, who I believe are sort of managing the implementation of ARDENS. But both of those organisations have said, you know, most of that data is quite easy to extract, but they would need permission from GP practices to share that data with the ICB. And I just wanted to open it up really. Has anybody got any comments on that, and do people sort of think this is a good way to go? Is that you, Joe? Sorry, apologies, I can't see your name. Yes, it's Joe.
Yeah, sorry, just a quick one. It's really just to see if anybody else has been having any issues with their the fit, not the fit test, but the results coming in to EMIS not recording the correct codes. We've been having quite a bit of that, and I don't know, Kate, whether when you're doing your audits of that, whether that's being flagged or not.
So Hayley's popped her hand up, and I know Hayley and I have had some conversations. So I haven't done any data collection yet. We're sort of just starting the conversations, but obviously I believe there's been some issues around the coding. Hayley, do you want to sort of update? Because I know you've been sort of talking about this for a while, and I'm not sure whether anything's changed.
Yeah, so Ben, the business manager, has kind of encrypted this code, so when the fit test comes back, it's coded as quantitative fit 2-week weight. So then I can then run a report to see what's outstanding, what fit tests are still outstanding. So hopefully on that side, because before I was coding everything, I was having to recode because the GPs weren't coding when they were requesting the fit test. So now hopefully it's picking it all up. Before it was showing 0, but now it's being picked up when the results come back. The only issue is that the results are still taking quite a long time. Sometimes they can take up to sort of 14 working days. Some of them are to come back. So that's obviously then when we lose out on the DARES.
So the payment, you mean the IF payment? Yeah. I suppose it's interesting because obviously, Hayley, you work for the Arden PCN, and not all PCNs have your kind of post, and so I guess that, you know, if it's not being coded at point of request, then there's going to be an issue there, isn't there, regarding payment? Michelle, you've got your hand up. Have you got something to add here?
It is important for us to sort of hear if there are delays from a lab perspective on the turnaround times, but equally we wouldn't want to get everything if it's a delay owing to the patient, because that's when we audited it previously. It was that sort of, you know, the lead time in terms of them by the time they've done their test and then they send their kit back, and then generally we're told by the lab that once they get the request in, it's turned around in 24 to 48 hours. Now, we haven't had any performance monitoring from them, so I'd like to go back to them with primary care perspective if that's not happening on the ground.
No, it's not.
I know it's very early stages and we have got the pilot up and running, I guess, to test that out. But that is, I guess that is one of my concerns, because we're starting to, all ICBs are now starting to really hone in on fit, and actually, you know, we could be breaking a service here, and I'm not sure that we've got the assurance that it's able to cope with the demand. So we need to have that wider conversation. Absolutely want to support that. So please bombard us if you've got concerns or examples.
I know from my PCN, obviously I cover all of the 7, and I'm notified of every single patient that has a fit requested. So then I will then put them in my calendar to remind the patient in 7 days to make sure they're posting it back. And there's been times where they haven't even received it in 7 days, so I'm having to re-request it again. And then they, like I said, some of the results are taking sort of 2 weeks sometimes to come back.
I know that they have flagged an issue with Royal Mail with us early doors, so that was picked up when I was on holiday. Just come back to sort of say that is going to cause delays with the going out and the coming in. So I think what I'll do is I'll take an action to just pick up with the path manager what the current state of play is.
Thank you. Eloise, did you want to come in?
Just to let you know that we've got 3 new data leads for Nuneaton and Bedworth PCN. So if you could you drop an email to Lena and ask her to introduce you, so they can discuss further. How we basically work it is that every time the fit referral is generated from the from the referral tree, the SNOMED code should be automatically added, so the clinician doesn't need to remember. So that should be picking up all those problems. But I'd like to echo, I don't know, in Hayley's comments. You know, in Warwickshire North, I'm also speaking to patients and saying, you haven't returned your fit test, you really must do this. And they say, well, we haven't got the test kit yet. So I think it's, you know, it is a problem, and that wasn't picked up in the previous presentation that we had.
Okay. That's interesting what you said, Eloise, regarding when you do it using the referral tree, yours is getting automatically coded. And I wonder whether that's something that we could have a discussion with Ardens about, because I believe the rest of the system are on Ardens. I know Coventry are, and I know South Warwickshire are. I'm pretty sure Rugby are as well. I'm not sure we've got anyone from Rugby on the call today. And that, for me, would seem like an obvious thing, that when the GP is making the referral, it's automatically coded. Hayley, what do you think about that? I'm looking at you because I know that you're the one that's had all these issues. You're on mute, Hayley, sorry.
Yeah, I think that that sounds like a good idea. I know that Ben only does it for certain people, because I think it depends on the practice, and it depends on what kind of software they have and what template they use and things like that. So I know that, like I said, I've had to go back even when they use sometimes even if they don't use the Macmillan template, it even depends on the referral, how they code the referral as well. I've noticed that won't pick it up either. It has to be the specific referral form has to be used, because if they just use a certain referral, it doesn't pick it up either. So I've had to keep going back in and putting in certain the templates, or actually coding it as fast track to suspected colorectal cancer, because sometimes it won't even pick it up that way either.
Do your secretaries not keep a separate list of all the 2-week waits?
I get sent them all.
Yeah, so do you not keep a separate? So our secretaries keep a separate spreadsheet with
Yeah,
all the 2-week waits on.
yeah, but they will do that, and then I get sent them all, so I can follow them all up as well.
Right, okay.
But I don't think anybody else follows them up apart from me. I think it's just me that follows them up.
Okay. Sorry, I've joined the conversation later, so
That's okay.
That's okay. I'm just conscious, is there anybody else on the call who wants to sort of add any experience that they've had around requesting fit and coding specifically? I'm looking at my Coventry colleagues. Pete, Helen, you're in my eye line, apologies. Have you made any requests yet for fit, and how's it working?
Yeah, I don't know. Like I said, I haven't, since starting the pilot, I haven't had anyone for 2-week wait colorectal on my side, so I can't really say how it's going. But like, I think historically, like when I've been requesting a fit test, it probably hadn't been. I'd been relying on the secretaries whether to how that got coded. I know they would have sent off the fit test request and things, but I certainly wasn't putting a direct code into the notes, and I wasn't always using a template or anything from that fit test. I was using the template when I was doing a 2-week wait referral, but now, you know, if you want to code that quantitative fit thing first, it sort of is a bit reliant on someone remembering that code. I'm sure my secretaries do, but I can't. That code goes in.
So when our form's been added, the new form that was sent out with the pilot, the code that is attached to using that form should be coding it as the code we need to use. But historically to that, because you were sometimes using the same form as the lower GI one, then historically it could have been, and I guess going forward, if you're using the lower GI form, it will code it as a lower GI referral rather than a fit referral. But every lower GI referral should be having the fit referral, so they should be kept anyway. Those you should be searching for both codes, I would assume.
Yeah, I'd agree. You need it so that when it is a uniformed form, effectively, that's got both on it and not sort of separate, then it needs to make sure it codes it as both, not just a 2-week wait, but also a fit. That's something that does need to be highlighted.
Yeah. I've got Suzanne and then Naya, if you wanted to add anything.
Yeah, I'm coming at this at the other. Hi, I'm coming at this at the other end of someone who's fairly new to it all, and actually where Peter's saying the same thing, that I'm new to all this, that the codes don't automatically go in when you request the fit referral. And what I was going to say is that obviously there's quite a few people like Hayley have done a lot of work on the coding, and I, as someone who, we've only just got ARDA managers, so we've not really managed to drill down where we're missing, would really appreciate it if people who have spent a lot of time and found the correct codes and stuff are happy to sort of share that with us, because we've not got that far yet. So that would be so useful for us, that people who've put a lot of time in, I'd really appreciate them sharing that, so I can kind of get going on it all. So
thank you, Suzanne. And Naya, you got anything to add? I think you might be on mute, Naya. I can't hear you.
There you go, that helps. Hi, there you go. Sorry,
I
think I joined a little bit late, so you may have already gone over this, and I apologise really. Just thinking about coding. So when we just the coding, it's the quantitative immunochemical testers that you're coding at. I think we had our kind of peer group meeting quite recently, and a lot of people are still kind of coding initially as provision of, really, which obviously isn't the coding that's kind of searched on really. Is it still okay to actually just use the kind of the quantitative code from the outset when you actually put the referral in, irrespective of whether you've got the result? I think a lot of practices within our PCN have just sort of said, is that correct to do? Are we going to get a hand slap for doing that, even if we don't have a result back within that 2-week time frame? I don't know. I think it might have been all answered already. I don't know what other PCNs are doing, what codes they're using.
So I think the issue is, and correct me if I'm wrong, Hayley, because you're closer to this than me, but I think the issue is that it's not about the requesting, it's more about it being recorded correctly, so you get your IFF payment. Sure. Is that right, Hayley, from your perspective, that what you were coding it, but it wasn't showing on your log of IIF? Yeah. Is that correct?
Well, and it's the result as well, so it needs to be coded, but it's the actual result that comes back. And that depends on the time frame. Obviously it has to be 7 days before or 14 days afterwards, but it's more the result that if it's too late, or if you don't refer or request within so many days, that's when you don't get the payment. So when I've run reports back, we miss out on quite a lot, because it's a delay in the results. Yeah. So the provision, I think it was it you, Naya, that said about this, that the provision will still pick it up, that it will still come. Yeah, so if you go through your DES, I don't know if you can see, if you run a report on the DES payment indicators, it will show you all the people that have had the fit and had the 2-week wait, and then the ones will be excluded, and when you click on those, you'll see the ones that are still waiting for their results. Got you. And that's why you don't get the payment.
Got you. That's helpful.
And I'm just thinking all of these discussions are saying to me that we need some sort of clear guidelines on how everybody needs to be doing this, because obviously it's new, and I don't want people to sort of potentially miss out on payments. Would you agree with that, Michelle? I mean, I know that Zoe's sort of leading on the pilot and sort of next steps. Yeah. And this might all be something she's doing.
Yeah, I think it's really interesting to hear sort of the conversations, and we would be happy to sort of pick that up with some of the primary care expertise. I think just listening to what people are saying, if you're not getting paid and it's owing to the lab not providing you with a result quick enough, I think that's an issue we need to address. And we need to understand that we need to equally provide evidence to the lab to say practice X have submitted 40 requests and 20 of those haven't come back because of lab delays, and we need them to investigate that, because as again potentially there is an income impact, isn't there?
So are we supposed to be putting, I know the first bit is capturing them and then entering the result in order to get payment? in, you know, that in the spreadsheet there was a specific way of adding the result.
You're talking about in the, as part, you mean as part of the pilot, not as part of the
pilot
additional. Yeah, I'd need to just double check on that because the project lead that's been leading on that isn't on the call. So can I get back to you on it? Is that okay?
Yeah, just because I haven't had time in the last 2 weeks to go through all the results, and I haven't got anyone from admin who can do it. Probably why you haven't had any results from me just yet on the weekly email.
Okay, I think we'd be happy to slip that time scale.
Okay.
Yeah, I think it was put in there as an important sort of piece to understand what was coming through, and I guess build an understanding of how those results are going to support secondary care in their triage process and their risk classification.
When we get the result though, secondary care should already have the result, right? On CRRS.
Yeah, they should.
Yeah, okay.
Yeah.
Just sorry to go back to the coding. The codes we're using here, if anyone wants to know, is fecal occult blood test requested, and then first fit reminder, second fit reminder, and then the fast track referral for suspected lower gastrointestinal cancer. They're all on our search criteria.
There's another code which says quantitative fit or something.
That's for the results, isn't it?
That's for the results.
Yeah.
My question is, does that, when the result comes in, does that automatically code that?
No. That's what they want us to do manually, and that's what I haven't had time to do.
Yeah.
Yeah, well, what I could do, I could ask the business manager maybe to send me, so he has added a code that will automatically code it, so I don't need to code it anymore. So that would save anyone a job then. So when the results come through, you don't actually have to code it, it's already coded. So if I speak to Ben today, and then maybe I could send it to Kate, and then Kate could forward it on, so everybody's got the code, and then that will save, obviously, because that was the initial delay. Sometimes people will only, it was the Path Lab was only sending the results to certain people, and those people are on annual leave. So then by the time it was actually put on, you were missing out. So that's why he's kind of encrypted a code so that it automatically, I don't have to do anything on that now. I only have to chase the patients to make sure that they are posting the fit tests.
That sounds safe.
Okay.
Yeah.
Okay.
I'll ask Ben to send it me over so I can share it, perhaps.
That might be something to take back to the lab as well.
Sorry.
I think they can code it from their end when it comes through.
Okay.
As well.
Have you got anything else to add, Pete? Sorry, you had your hand up, and I didn't know if you.
I can't remember now. I think I was half answer, then Amar was mentioning that, but I think it was on the IIF sort of payment, because obviously we've got sort of two conversations here, because Amar's talking about the fit pilot, which is some bits, but it's coming into the IIF thing. But surely from a payment point of view for that, the point of the pilot is going to be that you're waiting for that result before you're sending your 2-week wait referral, and therefore there is no, you are therefore guaranteed that payment, because you've not made because you've definitely got the result when you've made the referral. And that's what I think the pilot's point of view is, because otherwise at the moment what we were historically doing, and which we may, who knows what the actual end method will be, but if you're sending your 2-week wait referral and your fit test at the same time, that's when the issues come in, because you're not necessarily getting your result in that 3-week time frame, which is what the pilot's trying to change, with adding in a slight delay to the patient. So I think that's what we need to, that's what's going to hopefully help that part.
Yeah. Okay. Hayley, have you got anything more to add? I'm just trying, I think I'll try and sort of wrap this conversation up, and I think it sounds like there's a little bit of confusion out there, understandably, and we need to sort of firm up the guidelines of coding and processes, etc. So I've recorded an action, and we will obviously clarify processes and codes as a result of this discussion. I hope that's okay. I wanted to just move on, and if anybody's got any views on sort of potentially PSIT and Arden sort of sharing some data with us as an ICB, so we can offer targeted support, I guess. And for example, I'm thinking about maybe one of the QOF targets around cancer care reviews. If there's a PCN that has a lower percentage of cancer care reviews, that's potentially an information for myself and Lisa to approach that PCN and offer support around maybe training or using the template on EMIS, etc. So do people generally feel that that's a good idea and for happy for us to have that information? And just to really reiterate, it's not about performance management. We're not really interested in who's doing the most of anything. It's really just about our support. Eloise?
So I'd first need to understand what data it is that
I'll just go back.
PCIT
sorry.
would.
So this was just the suggested data.
Yeah, I get that, but it's. What I'd need to do is be able to put it into a form that I can communicate back to members and get their consent. So having clarity about exactly what information, so that I can communicate that, would be helpful, particularly around the template use.
Yeah, okay, so that's so I mean, I've had some initial conversations with PSIT who said that the information that I've listed on that slide is quite easy to extract from their system, but
Yeah,
obviously
I'm
they
sure.
would want
That's
permission from you guys, and that's perfectly fine. So so do you need more information than what I've put on the screen, Eloise, or I'm just really, it's just about sort of percentages and numbers, and I mean, some practices may not be making any contact with non-responders, and that's where we can sort of offer support. Do you need more information than that, or is that enough to go to to your members?
It's the information about the template use that.
Okay, so
yeah.
So you mean like the safety net and also the cancer care review? Yeah, okay, that's fine. I can pull that together for you. Pooja?
Hi, Kate. Thanks for this. Yeah, I just wanted to say, is that something that maybe you could directly communicate to practices about, you know, in the area, and just say that, look, we've trying to do this data collection. Is everybody happy with it? And
yeah,
see what you get, rather than piece individually asking all the member practices and trying to collect the information and sending it back to you. Just an idea.
Yeah, and I think, Pooja, I'm not sure if you missed the first part of the conversation, and what we were saying was that this data we wouldn't be extracting from the practices, because that would just be too difficult. We'd be getting it via the Ardens tool and the PSIT tool, so it wouldn't be a burden on the practices. But yes, I mean, your suggestion is going sort of via, would you say, the practice managers, just to get that agreement. That's absolutely fine. I can do that, and if that's the best way to get the approval, then I can arrange for that. That's fine. Pete, did you have anything else to say?
No, well, I just, it sounds sensible to me, because it's always useful to go, you know, to go back to the practices, and so you can go, look, here are the bits that you're so you've got some evidence to give them to push it. So I don't think it's that you're getting practice to do any extra work, which is what they don't want to do, but it's trying to find that. But if you've got something where you can go, look, this is where we are. Do you remember that's the whole point of this, is you want to know which practices in your PCN, so you can get everyone up to a level playing field. So I think it's a sensible thing, and I'd offer feedback with our PCN and check, but I wouldn't see a reason why not.
Brilliant. Great, thank you. I can't see any more comments. I think we'll wrap this conversation up. Thank you very much. I know we've got fit on the agenda a little bit later on, and we may have covered some of what you were going to cover, Michelle, but I think it was a useful discussion to have anyway. Okay, moving on. I'm going to hand over to everybody now, just to give us a brief update on what's been happening in your PCN, if that's okay. And I will, we've sort of said 5 minutes each, and I will just work through the list. Pete, I'm afraid you're on the top of my list, probably because you've got your hand up still. Okay. So if you want to fire away with just anything, if there's nothing, that's fine too. You know, there's no pressure, but just anything to share.
I'll keep it short. just I think our network's just starting on the fit pilot really. So and probably because it's been summer holidays, I'm not sure where everyone is on which practice. Amar's obviously started it for, and we've just like last week really started it from our end because everyone's been on holidays and things. So that's sort of the next 6 weeks and see where that goes. And then we need to get started on some prostate stuff, which I'm sort of waiting to see what those links had come through and things, the searches. So I'll be feeding that back to try and work out some searches for the prostate sort of things. That's our plans.
Great, thank you, Pete. Amar, have you got anything to add? You're next on my list. Amar, you there from Forum? Sorry, Amar. Just wanted to get into, I know you're Pete's PCN.
So pretty much, again, summer holidays things. We have started doing the searches, but we haven't particularly started doing the full pilot. So my searches only go back 2 weeks, and out of the 7 of them, all the results are still pending. So yeah, other than that, we need to work on sending the text messages out, and we need to work on using the safety netting tool still. So once we've decided as PCN what we're doing for the prostate stuff, then I'll give everyone an update here.
Great, thank you, Amar. Hayley, you're next on my list.
Nothing really to report. I've just started running and creating reports for the prostate, so maybe next meeting I can give a bit more of an update. Obviously from our meeting I've kind of started to create like a recall list as well for the prostate patients that are discharged, and make sure that they're getting their blood tests, or reminders to have their blood tests done, but that's kind of, I've only just started to create those.
So that's patients who've had treatment and have been discharged by secondary care back into primary care. Is that right, Hayley?
Yes, that's right.
Okay, that's just any other, is that any other practices doing that, or yeah? Sounds great, thank you. Anything else, Hayley, that you wanted to share?
No, nothing. Just obviously, just with the payment, the debts and things like that. And there's a different one as well about the cancer support for primary care services.
Is that kind of,
yeah, it is the QOF. So I've just started to do that, and then just kind of about I spoke to a lady from Stratford yesterday, and just about coding. It's more for best practice about the advice given for sort of bowel screening and breast screening and cancer, the cervical screening. So I'll kind of code that as well. It's more best practice. Obviously it doesn't come up as a payment indicator, but it's just quite interesting to see how many patients we kind of do that on. So that's what I've been doing.
Brilliant. I think maybe in a future meeting, Hayley, that would be interesting to explore that a little bit further, just sort of see,
yeah,
you know, what kind of information you're getting. I think that would be quite good. Helen, I've got you next. Helen Dyer. Hi, Helen. I'm trying to look for. Oh, there you are at the top.
Hi. Yes. Sorry, I came in very late to the meeting. I think I started it. We have been looking at them, and we had worked out that the coding issues ourselves. So we're sort of onto that, and it'll be very useful to have the code come through to you. We've looked at some searches already around prostate cancer. Have you already done the prostate cancer discussion?
No, we haven't.
Okay.
Have you got any updates on the searches that have gone out? Or
So I've done the searches. It's just over 1,600 men over the age of 50 in Horsley Park. I've located 22 men black origin, and we've only got 2 on our records that have a positive family history. Bryony, who's our lead for the PCN, we've had a discussion about who we would target with texts, and the decision amongst ourselves for Unity was that we would look at family history and black men. I'd have a lot of misgivings, and this probably will feed into any discussion that we have later about sending out accurate texts to 1,683.
Absolutely.
83
Yeah,
and
agreed.
To time, and particularly as there is no verified, validated screening test, and I feel that we're actually sort of going down that route if we are doing that. And I would rather look at other softer ways within the practice to raise awareness opportunistically. That's my opinion. So that's it really, I think, for the
Right.
for the
Thank
moment.
you. Thank you, Helen. Eloise, you're next on my list.
Not a lot to update on, particularly to those areas. We have identified 2 new leads, non-clinical and clinical, but they're not fully up and running as yet. The plan to have a peer group meeting across all of the practices for support around screening, etc., is planned. I think the biggest changes really are not directly relevant. They're around developments in terms of improving palliative care and getting people to start using the EPACS system. So I'm not quite sure that fits into this meeting or not. The other thing is, in terms of cancer care review training, I suppose our feedback from a lot of practices is that the training on offer is far too long, and therefore would be prohibitive in terms of getting nursing staff onto that training. I think 2.5 days is an excessive amount of time for what actually we're supposed to do within the contract, and releasing your staff for that period of time is a major blocker. So I suppose that's one of the points of feedback.
I think, can I just come in there with just a little bit of information that surrounds that? When the cancer care review training was first sort of put out there to be delivered by Macmillan, before the pandemic, they were suggesting the course was a 7-day course, and if you want to do the course through Macmillan as an online thing, it's over 6 months, the course is. So we've reduced a lot of what they've said, and when we first were looking at the course, we were offering it as 3 days, and we've reduced that down now to 2.5 days. So I think a 2.5 day course is not that long if you're expecting the nurses to do COPD training and different things like that. 2.5 days is not very long, really, is it? To look at someone holistically from their cancer.
I think from the perspective
I would say
of
for the nurses to feel confident to do it.
I would say from the perspective of GPs and from primary care, the training is excessive, so it would mean that we wouldn't be able to be recommending multiple staff going on to the training.
I don't think you need multiple staff to go on it. I think one nurse from each practice would be plenty to go on the training. You could even look at nurses within a PCN, 1 or 2 nurses doing the training, but I think to expect them to feel confident to deliver the cancer care review, you need to give them enough education to feel supported to do that. Would be my argument. And I think from a cost perspective, for the QOF points for doing a cancer care review, you claim over £1,000 for that. The nurse's time to do a cancer care review will cost you £15. So before, when there was no funding for it, I know the practices were sort of putting up resistance to it because there was no funding. Now there is funding for the cancer care review. That would be, I think, it's about £1,200 you could claim for doing the cancer care review, whereas a nurse's time, £30 an hour is the most that you would pay a nurse with their own costs. So it's the money you can generate from the nurse doing the cancer care review is quite significant for what it costs the nurse's wages. That would be my comment. But I think the nurses that have done the course, anything less, they wouldn't feel confident to do the cancer care review.
Okay, well, I mean, we obviously have different perspectives on this one, but I've communicated with you know, some nurses who've got experience in delivering it, and some of them turned up and found the course very good quality, but they didn't complete it because they felt that it was excessively long.
There's nobody that did the course. There's no one that did the course that didn't complete it. No nurses from the last 40 that were trained. Nobody didn't complete it.
Mm-hmm. Okay, or maybe it's a more updated course then. But I think, you know, anyway, we have different perspectives. But if you want feedback from what is on the ground, what practices feel, then that would be my perception.
Thank you. Thank you, Eloise. Joe, I've got you next from Warwickshire East. Are you there, Joe? I'm looking for you. Joe Hamilton, are you still with us? I'll come back to Joe because I can't.
Do you want me to? It's Jenny.
Oh, hi, Jenny. Sorry.
Hi. Do you want me to fill in for Joe?
Please, apologies. That would be great. I'm just going down the list. So.
No, that's absolutely fine. We with the fit coding and everything. We've had delays because of summer holidays and also changes in doctors. So we're going to have a meeting about that in the next week, just to make sure the templates are being completed and then look at that. We've done most of the in-depth SEAs and Joe's collecting the information on that. Joe's done a social media campaign. So there's been a campaign done on colorectal and prostate as well. We were going to look at doing an audit on 2-week wait urology referrals and whether we were referring appropriately. I just wanted to ask about the doctor's clinical training, because I know there was training on the 10th of August, but there were lots of people on holiday. Is there likely to be another one?
There's another 2 actually, Jenny, in the diary. I think we've got an update on the prostate training coming up, but also just to say that if it's not possible for anyone from your PCN to attend any of the dates, please let me know, because Lisa and I can always run a separate session for your PCN. That's absolutely fine. It's an hour. Okay. We can do it over a lunch break, so that's fine. But we'll be sending the next set of dates out soon. I think there's one at the end of this month, and then there's another one in October. But we can put on as many that are needed, really.
Perfect, thank you. And
thank you, Jenny.
The Accurix, we need to get going on that because of holiday and staff issues. So we do have the recommended searches, but we just need to crack on with that.
Great, thank you, Jenny.
Thank you.
Okay. Apologies, I've got somebody called, is it Lee Madison? I'm not sure. Apologies, Lee, I don't recognise your name. Are you able to come on and introduce yourself?
Hi, Kate. It's Pooja. I'll introduce Lee. He's the new clinical cancer lead for GP Connect.
Sorry, yes, I remember now, Pooja. Sorry.
Yeah, no worries. I could possibly, do a bit of a feedback for our network for this last quarter. I think what we're working on is, for early help for people with new cancer diagnosis. And I think you did some training with our social prescribers, and we've just started having a little bit of go at that. And, we've had some practice referrals, which we started work on. Regarding fit tests, I did push for them, in our last network meeting. But I think this is news in terms of, the codes to be used and how they're going to come up in terms of searches, and would definitely like some help with that as to what codes we should be using and informing the practices of the same. Prostate cancer, we've not yet started the searches, but yeah, that's in the pipeline, and yeah, that's it really.
Great, thank you, Pooja. And Dr. Blike from Parkleys. Hi, how are you? Just if you wanted to just give us a quick update if possible.
Oh, hi, I'm not with Parkleys. I'm not sure why my NHS.
Oh, sorry.
Coventry Central, but I really don't have a lot to say. We haven't done any of the searches for prostate cancer. and we haven't really started working on the fit test side of things. So not a lot, I'm afraid. We've just been trying to get the safety netting sort of re-audited and to see if there's been an improvement on that front. But besides that, not much else has happened. Sorry.
No, that's fine. Just to say, if you need any support with the searches or the fit stuff, you know, just please drop us a line.
Oh yeah, absolutely.
And we'd be happy to help. And also, you've got the lung health check program coming, haven't you, to your PCN next? So that's in the pipeline as well.
Yes.
Thank you. And then Suzanne.
So as I mentioned already, we're still kind of trying to get our head around the fit and the coding. So I would like to meet with you, Kate, to go through that.
Yeah.
We've just got Arden's manager and are starting training on it. So we're going to start drilling down in terms of our data at the moment. I had a chat with our Federation IT guy about the searches for the prostate, and he's not optimistic in terms of data on the ethnicity plus family history, but we're going to look at what we've got on that. Okay. The other bit we did, which was slightly different, which you know about, Kate, is the network had a wellbeing festival on Saturday, which was part of the Eco Fest in Leamington, and we had nurses doing blood pressure checks, weights, and just I was along, sort of particularly talking to patients about screening, and we kind of we're giving them information on breast screening, bowel screening, and they seem to find that really helpful. So we just had sheets with the contact numbers for the breast screening, so a lot of people were asking not to opt in. So that actually was a really positive experience. We saw 318 patients that day. Wow. So, but we were able to do a lot of health promotion stuff, so we're probably going to look to do it again.
Brilliant. Thank you, Suzanne. And also, we've got your non-clinical training coming up as well, haven't we, for your PCN? I had a long chat with Amanda about that last Friday. We're going to be doing some awareness training, just with, I think, practice managers initially.
And we've got a new admin starting who's going to be part of supporting the cancer work, called Sarah, who's starting very shortly, which will help as well.
Thank you, Suzanne. Next on my list is Naya.
I am probably in a very similar position to the PCNs, actually. I think again, it's the coding with the fit. I think we're kind of at different points within different practices in the PCN. So I think that's probably an area that we just need to work on. I think on a ground level, we're doing the work. It's just not capturing it really, so it's obviously affecting the data. I think we started searches with the prostate as well. We've got a new care coordinator for our PCN as well, Amy Bradley. I don't know if you're aware of her, Kate, at all. I can
not yet,
the details,
but I will make contact.
But both Amy and Jane are due to book onto the non-clinical training as well, really, for the prostate. Really, so we've got somebody who's non-clinical identified now for our PCN, which is great. So that's it really as well. As I say, it's just the other thing is kind of trying to kind of blend in kind of more kind of auxiliary staff really as well. We've got our team of social prescribers who've worked quite hard really to develop resources to support a lot of cancer awareness, etc. So they're kind of being brought in with the screening side of things for the vulnerable groups really. So we get incorporating those into our sort of quarterly peer group meetings, which I think will be massively helpful really, just have a bit of a joined up conversation with them. And that's it really. One of the interesting things, one of the things that we haven't mentioned here is the teledermatology side of things. I know that there's been conversations, haven't there, with secondary care about how that's set, so we don't have a local service for that. But amongst the 5 practices within Kenilworth and Warwick, we just had a bit of a kind of a sort of just a bit of a discussion about what we felt about it as a PCN. I think within practices we usually have somebody who does dermoscopy. So the use of any kind of teledermatology, certainly within our PCN, has been very minimal. We hardly use it at all, really. So I think there's just been discussion about the value of a service like that, really. How is it going to add to what we're doing already? Is it going to change, or is it actually going to add potential delays into service, 2-week wait referrals, particularly from the 2-week wait skin side of things, really. So that was just a general kind of feedback from our PCN, really, that, anything like that, if that were to be introduced, it would have to be something that would add add, you know, to what we're doing really, rather than add a delay in, you know, to what we're doing already. But I'm guessing across the patch, GP practices work differently. Not everybody has a dermoscopy within in-house, so I can imagine it's not applicable across the board. Yeah, but that's it really. I think we're probably in a very similar position. We're post-summer holidays. We're just trying to pick up the pace a little bit now and move forward.
Yeah. Thanks, Naya. Just on the dermatology stuff, the teledermatology stuff, there's a survey that's gone out. I'm not sure. I'm hoping it's reached you. It's been sent out via the practice managers. I believe the closing date's tomorrow, Michelle, isn't it? And we're just doing some scoping, really, finding out. Sorry, Michelle, I'll let you speak.
Yeah, I was going to pick it up in my update, if that's okay, Kate. I've got skin on the agenda, so I think we could probably resend the survey to this group just to make sure people have seen it. But I'll explain, and I've also got John on the call who can chip in for anything from a sort of secondary care perspective as well. So we'll come on to that in my bit.
Lovely. Thank you, Naya. Pooja, we've done, and Bryony next, please. Bryony Straw. Hi, Bryony.
Hi there. Are you okay? Yeah. So Helen sort of told you most of the update. We have at Broomfield sent out Accurix messages actually to for the prostate cancer DES to men over the age of 45 for black and ethnic minority ethnicity, because that came to just 93 patients. So we thought that was kind of an achievable number rather than overloading the system too much. Haven't looked yet to see what the response has been because I've been on holiday. So. But yeah, so yeah, we've sent a message out to the 93. We'd also looked at for one of the other DES, we'd looked at learning disability patients who were non-responders to cervical smear screening, and I've written a letter with an easy read leaflet from Dro's Trust, sent that out to them just to explain a little bit more to see if that helps improve uptake. I've not audited yet to see if that's made a difference though, but that's what we've done really. Yeah. Great,
thank you, Bryony. Okay, and Lena, have you got anything to add? I know Eloise has done an update for your PCN. Do you want to add anything? I'm sure she's there. No worries. And Helen from Priory Gate, Helen Tyrrell.
Sorry, 1 second.
It's all right.
That's mine just called me right this minute. 1 sec.
She's the last on the list, so I can't. She's back.
Sorry.
It's all right.
Oh, gosh. Always because of tight. So yeah, I'm Helen Tyrrell from PC Navigation. We are very much like everyone else, picking up the pieces of the summer holiday. We have started doing some of the prostate searches, and we'll start sending out some of those text messages. We've got a meeting coming up, and actually one thing we've realised looking at them is we're not great at coding. We're not great at coding our ethnicity. So that's something we were going to highlight to all the GPs, just to say, don't forget to code it. And I know that reception kind of thing. We definitely need some help on the FIT coding. Thank you very much. We're still going with the text to our 59-year-olds to tell them that we'd very much encourage they take part in the 60-year-old screening. We want to do the prostate training. I'm really sorry that one, just everyone's on holiday in August, and then those that aren't on holiday are covering everyone else who's on holiday. Yes. It's never going to work. So I can't remember the other dates, but if you could recirculate them,
of course, yeah,
that would be great. And we've had lung health, which was very successful. And I have to say, I don't know if I said at the last meeting, when they missed a patient out and we highlighted it to them, they got them in within days. They were great. They were really easy to communicate with, and our patients, yeah, it's been good.
Oh, thank you, Helen. We've got a bit of an update on the targeted lung health check programme later on, but that's really good to hear positive feedback. Thank you, everybody. That's everybody on the list. Apologies if I've missed anybody. I don't think I have. And let's move on. I have no idea where we are with the agenda. I'll keep going. So just to give you a brief update on the education, and a lot of you have mentioned sort of the various education sessions that Lisa and I have been delivering. We've been doing some sort of staff training actually within our own organisation, which has been really positive. Done cervical screening, and we've got prostate cancer this week. It's urological cancer awareness this month, so we've got a staff awareness session. As Pooja mentioned, had a really good session with the social prescribers and care coordinators at GP Connect. Just to say that offer is there for everybody, anybody who has social prescribers and care coordinators that are involved with cancer patients. Myself and Lisa will be happy to train them. We've got a session in Alliance Teaching Practices, which I believe is Connect as well, doing some training around basic awareness, screening, that kind of thing with non-clinical stuff, and also the PCN, the Leamington PCNs, which is going to be held at Warwick Gates Family Health Centre. So lots of education going on as always, and if anybody has any particular sessions that they would like, please just make contact with me or Lisa and we'd be happy to help. Lisa, do you want to take over from here?
Yeah. So the prostate cancer awareness training, as you know, it started. We decided to put a couple of sessions on in August just to see if we, you know, if anybody that wasn't on holiday in the school holidays. But we did have, you know, a significant number attend. So we did one non-clinical and one clinical training session, and you can see what we went through. It was an hour virtual over lunchtime. We've got 4 more sessions booked to roll out, and we've also got a slot on the Coventry and Rugby PLT in October, so we've got 45 minutes there to talk to everyone, so hopefully that will capture a lot of people, that content then.
Brilliant, thank you, Lisa. And do you want to carry on with Cancer Care Review? I know we've talked about this briefly.
Yeah, so the Cancer Care Review training, first course starts tomorrow, and then there's 2 more courses, one in October and 1 November, sort of timing it. They're booked via the Coventry and Warwickshire Training Hub. The obviously benefits for sending your nurses on the training is that they can do the cancer care reviews. As we've said, they're a lot cheaper resource to do the review than the GPs. And also it's a way of investing in your nurses. Also, the nurses, because of cancer patients, 50% of cancer patients have got another long-term condition. So there is an opportunity for your nurses when they're doing their other long-term conditions, they could combine the cancer care review with another long-term condition review, making it more of a holistic approach for the patient, so you can cover all of the issues for that particular patient rather than making it disease focused. These nurses that then are in your PCNs could link in with yourselves and support this work that you're doing, because they will have a better understanding of the whole cancer agenda, and they maybe can help with the issues. They will also cover all the prostate awareness and all the different things, screening, as well as doing the reviews, completing the template and everything. So that's what the course is involved. So any questions, I'm really happy for anyone to email me and say we get started tomorrow. We've got to date about 22 nurses that have signed up for the course over the 3 courses, but obviously welcome anyone else and got capacity for more if anyone wants to join.
Thank you, Lisa. And then just finally, I think
Pooja asking a question.
Oh, sorry, apologies. Sorry, Pooja, I missed that. Fire away, I'll go back to the cancer care review.
Thanks, Lisa. Just a quick question. Can physician associates attend that training as well? Is it open for them?
I think it depends on the skills of your physician associate really, and what sort of things they're doing. Physician associates are very different in different PCNs and practices, and it's whether or not you feel your physician associate would be competent to do a cancer care review with that training. It's aimed at the nurses, the practice nurses, because it's similar to do the long-term condition reviews. But if you've got a physician's associate that you think would take on that role and be confident to do it, then absolutely. And I think the nurse associates as well, I think they would be appropriate staff that are coming online into primary care to look at doing the training.
Okay, thanks, Lisa. Thank you.
Thank you, Pooja. Yeah, so the Cancer PLT, I think everybody's been made aware of the dates, but I'll just reminded you that we've got 2 again in November. We've got the, it's sort of an annual thing now that we have the whole PLT dedicated to cancer in the month of November. Coventry and North Warwickshire on the 16th of November, Rugby and Warwickshire South are the 24th of November. So please put those dates in your diary. And this year we are focusing on the patient journey. Very much looking at the journey from sort of point of screening, point of diagnosis, detecting those early symptoms right through to the point of referral, looking at the patient experience. We've got somebody to come and speak to you about the psychological effects of treatment, and then the workshops is going to be around living with and beyond cancer. So Lisa's going to be doing one on cancer care reviews, but also there's going to be some workshops on some of the side effects of cancer treatment and how those are managed. And then just finally a session on end of life as well. So really good agenda. We've also got, I think we've got 2 patients who are going to be telling their story. That's right, isn't it, Lisa? Yeah, that obviously, as you know, that always makes the PLT much more interesting when we kind of get that input. So we will keep you posted. I will be emailing some of you for hopefully doing some other sessions. So watch out in your inbox. Okay, and I'm going to hand over to you now, Michelle, just to do an update on cancer transformation.
Okay, no worries, Kate. Thank you. I think the first item on the list, I don't know, my slide's not moving. Julie, could you just move me on, please? I think we've actually covered a fair chunk of the points here on the FIT pilot, but just really to sort of say there's a number of practices in Coventry have signed up to the pilot, and this primarily was focused on understanding the outcomes of a change in process. So I think Pete sort of highlighted that this new process allows primary care to request the FIT, and then once that FIT result comes in over a 2-week wait period, they would then refer on to on a 2-week wait or not. I think once we'd implemented the pilot, we had some further guidance from the British Association of Gastroenterologists, who have actually recommended the process that we've put in place. So whilst we've got the pilot going on and recognise that there'll be some delays to that owing to sort of busy August period with annual leave, I think we're looking now to really sort of motor with that based on that guidance. We'll be looking to have some discussions with key stakeholders, and I guess I've just suggested on the chat, given the conversations around FIT and recording and information about the pilot, as whether we have a workshop to sort of really focus on that. And it could be that once we've gone through that new process that we've got in place with the pilot practice, some of you may actually say, do you know what, this may work better. And I think in terms of the sort of safety netting around what codes to use, when to text patients, and then when to refer on, I think that will all sort of help and make that a much slicker process, but we can have that conversation. So we will set that up. What I'll also do is I'll ping over a contact name, so that if you have got queries on your FIT results where you believe that the lab are not sending them back in time, we would be happy to raise that with them, because we have got that relationship with them. The other thing to say around the new process, at the moment the bowel screening team work pretty much on a manual, they use a manual process, and I think given the volumes that are coming in as a result of the new QOF requirement, also as a result of the increased 2-week wait referrals, which has primarily been impacted as a result of the Bowel Babe campaign. I think some of you may have seen sort of the national press around that. I'm quite keen to sort of where practices sign up, we would be keen to implement the new referral form that we've put in place, because what that does is it generates the referral sent over, and it generates a patient letter which can be automatically printed off by the hub, and they can send the kit out straight away. At the moment they are using your referrals for fit and manually writing, believe it or not, the addresses and sending that out to patients. So A, it'll reduce error, and B, it should save a lot of time. So I think there's a fair bit of learning. Someone's just put something around the so is that you, Vinod, around the turnaround time? So I think there's a number of issues, Vinod, which we're going to pick up with the lab. There's Royal Mail delays, there's patient compliance, and there's their manual processes, as I described, and also they are the provider of fit to many different ICBs. So they do the bowel screening piece, and they always have done for a number of years, but more recently they've been commissioned through ICBs to do the fit for the symptomatic pathways, and I think it's around the volume. So myself and my colleague Zoe will pick that up as an urgent conversation with them to find out you know, what their sort of turnaround times are, and they should be able to provide us with that. So we will come back on that, and I'm happy to include you in that update, Vinod, as we move along. If we could go to the next slide. Just to say there's a national focus on fit, you've probably picked up through other forums, and a regional task and finish group had its first meeting last week. And as a result of that, what we've decided to do, given some of the conversations around embedding fit in primary care, and also around sort of increases in referrals and some of the wider pathway issues, we've decided that we're going to set up a system-wide workshop in October to sort of pull all of that together and try and work across, I guess, the 3 trusts with our key stakeholders. And then what I think I've already alluded to, we're really keen to have the conversation around how we improve the fit pathway, so how we support primary care to make the changes as described in line with the British Association of Gastroenterologists. So I think this one's not going to go away. I think this is going to be on hot topic. So we'll keep this on the agenda and we'll keep you briefed. And I'll be in touch about the workshop that I've alluded to in the chat. Does anyone have any questions? Feel free to come to me if there is anything. Happy to help where we can. So in terms of challenge pathways, I thought it was just really to give you a bit of a heads up. We do try and include this information in the newsletters that we share. But I guess across the board, across the 3 providers, increases have been noted in lower GI, gynae, head and neck and skin. And I'll come back to skin in a minute, but we are working closely with the trusts, and Hazel's obviously involved in that process, to just really sort of look at some of the 2-week wait referrals that are coming in, to understand what's actually coming through the front door and what sort of pathway transformation options we've got to change things around. Now, we've put a bit of a sort of a milestone date of October here to pull all of that information together. And this is not exhaustive, but it just gives an idea of what sort of things we're going to be looking at, because you do hear, I guess, rumblings in the background. We want to really sort of evidence some of the questions that are being asked. So for some of the tumour sites, really understanding and drilling down if there's an impact of non-physical examination of the patient in primary care prior to referral. Also around sort of the lack of clinical information to determine if the patient meets NG12 guidance. So I know Hazel's already done an audit of head and neck at South Warwickshire, albeit it was around 60 plus referrals, but I know that around 10% didn't demonstrate any evidence that they met NG12. And actually, what other pathways do we need to put in? We've talked a long time for head and neck around sort of globus pathway, which doesn't necessarily mean that the patient needs to be seen in the 2-week period, but we could do something else, you know, and potentially use some funding that we've got through the Cancer Alliance to test that model out. We're really keen, and we have always worked with the booking teams to make sure that all of our GP practices have got access to the 2-week wait referral forms that we've updated. And then just, I guess, more broadly around sort of the quality information. So I know that trusts have shared case studies with us, and this will form part of the evidence and the feedback, where, you know, some patients will not have any information around the fact that they're wheelchair bound and they turn up for their endoscopy, and then it's, you know, patient can't always have it done, and it's the impact, I guess, not only for mainly for the patient, but, you know, what does that mean for sort of secondary care services, and then some solutions. But we'll do that with consultation with stakeholders. Going back to skin, there's a number of local conversations that have just sort of ramped up in the last few days. So particularly for UHCW, I think, John, I know you're on the call, you've seen in Q1, was it a 25% increase on previous quarter last year for skin? I think John's still on. Anyway, we can
that's
send
right,
you.
Michelle. Yeah. Thanks.
And again, similar for lower GI. So what UHCW are going to be doing is a teledermatology pilot. So when referrals come into the trust, they'll use a teledermatology pathway to, I guess, streamline the patients and decide what next. We're also, I think Kate talked about the survey that we've sent out to primary care, just to understand, because we know teledermatology features in the PCN DES, really to understand what's happening in primary care, how we can support you, whether there is an appetite to run teledermatology, what expertise is in primary care and how can we utilise that and possibly bring that into the sort of secondary care discussions. And also alongside that, we're looking at doing a small skin AI pilot and would be looking for practices to, I guess, offer to participate in that. We've had a very brief meeting yesterday to just think about all the things we need to consider. And we've set a date, and I can't remember it off the top of my head. I want to say it's around the 13th of October, where we will meet with this skin AI provider and just run through what those what that pilot pathway might look like. And we would be interested in inviting primary care clinicians to that who have got an interest in hearing a little bit more about it. You may think you want to sign up and then you may attend that and then decide not to, or the other way around, you might have some reservations now, but actually once you've heard what they've got to say and how it might work, you might want to join. So we will write separately with a bit of a briefing paper around that to just give you a bit more of a heads up on that. Has anyone got any questions on anything so far that we've talked about? Okay, so we'll move on.
Michelle, I just put a little question in. You know the teledermatology?
Yeah.
Yeah, is that based on photos or videos?
Yes. Photographs, as far as I'm aware. I think photos for the UHCW secondary care teledermics photos, isn't it, John?
It might not be too difficult to make it a video, because then you can actually go around the lesion and see the shadows and things, because if it's a tumour, I think dermatologists would prefer that, I'm sure, if you ask them.
Yeah, so just coming back on that, Michelle, actually, so I think you're really helpful feedback, and I think we would want to incorporate the design of any form of pilot with colleagues in primary care. So yeah, really good point, and I agree the dermatologists would appreciate more so video capability with teledermatology. Yeah.
So
thanks.
I don't think I think more to, on skin, but watch this space. Again, feel free if you've got any questions or you want to be involved, put your names forward. And this really, the challenge pathways piece is we have to report this level of information to boards, and it's just really to give you that sort of overview on what that looks like across the system around 2-week wait referrals. But I think that's it from me. Have I got anything else, Julie?
That's it. I think that's it, Michelle. Thank you. I just popped that graph just to show the kind of the trajectory, really, how it's sort of gone up and down, but you can see everything's on the increase sort of from April onwards, really. I think that's quite a useful diagram. And then there's just one more from me regarding primary care cancer navigators or leads, whatever you want to call them. Had a interesting meeting with the care navigators, the trust care navigators at Swift, and also some of our primary care leads within South Warwickshire. So I know Hayley came along, and also Warwickshire East with Stratford. I think probably there was representative from all of the PCNs, and obviously I'm really conscious that depending on the PCN, the roles are very different, but it was really interesting to sort of map what secondary care navigators were doing, and also the contact that they had with primary care. And I think what we've discovered is the picture is different in every trust, and it's different in every primary care network, so it's not an easy thing to find a solution to. And I guess looking at the different roles and looking at how well they work, we want to sort of have a discussion around whether we could have a standardised role for that non-clinical primary care navigator, and what are people's views on that. I know that everybody runs their PCN in a slightly different way. I think, if I'm right, Hayley is probably the only full-time cancer care navigator working in primary care, but please correct me if I'm wrong. And I guess it's just opening it up really, if anybody's got any comments, and whether obviously the PCN has got another few years left to run, and whether PCNs are thinking about getting a sort of more non-clinical cancer person in post, and what that post's going to do. Has anybody got any comments? Sorry, it's a bit waffly, but we're just doing some mapping really, and just sort of trying to find out what's going on, and whether that, you know, if we had a standardised job description, would that be helpful to PCNs? Has anybody got any comments? I'm looking for hands. I know we're getting towards the end now. I'm just going to pull up the people. No comments from everybody. Oh yes, we've got a hand. Thank you, whoever that is. Suzanne. Thank you.
I can't really comment specifically on the cancer care navigators, but as a general issue with the network, recruitment's a nightmare. So I think it's a fantastic thought to have a full-time cancer care navigator. I'd love one, but we're having so much trouble recruiting into so many of our network ARRS roles, care navigator roles generally, that even if we thought it was a good, you know, it was a good thing for our network, I'm not sure how easy it would be to recruit right now. So yeah, I'd love it, but watch this space.
Oh, thank you, Suzanne. Naya, do you want to come in?
Yeah, no, I think it would be great actually. It's just pitching it at the right level, isn't it? Because obviously you want somebody who has a little bit of local knowledge and input as well, but actually overarching, so you can actually bring the challenge that certainly we have as a PCN is that obviously exactly the same as recruitment, you know, we've only just about managed to get a care coordinator for the PCN, but nothing as niche as a primary care navigator at all really, and capacity in terms of what roles we give those individuals. So doing this kind of work ends up falling on the clinicians, which none of us have got a capacity for really. But when you have something across sort of, you know, PCNs and what have you, I think that's great, because you've got kind of a uniform discussion, you know, and we can actually share ideas and have one person that oversees that really, but that person still needs to have local awareness of what the individual challenges are across PCN. So I think in theory it's fantastic. It's knowing kind of what level to pitch it at, because if it's too removed from the PCN, then that communication gets lost, isn't it, really, as well. But yeah, I think something like that in theory would be great. It's just who that will be, and then how they would tap into the individual PCNs, etc., and then share that on a wider platform.
So would you say, Naya, that sort of like a standardized role description, and I'm not saying people have to stick to that explicitly, but would that be helpful?
I think so, because then it's very clear then, isn't it, really? Yeah. And actually it's also very clear for them, but also very clear for us in terms of what we are turning to them for, you know, and what we can actually get from them. I think that sounds sensible.
Okay, thank you, Naya. Pete, you're next on my list. Do you want to comment?
Yeah, I was just pretty much everything Naya just said, because we don't really have one, and it's sort of, you find that everything gets passed down from you to us, and then we're trying to work out how to do all that and pass it on to the individual practices. And some practices are good at engaging and some less good, and if you had someone who was there helping with a lot of those searches and those coding things that Hayley seems to do, the useful bits that as clinicians, we don't have time. We may know sort of the bits about the cancer and stuff, but all those other bits we don't necessarily have the time and to keep going back and forth. And that once you're done, you're in your practice doing your bit, but you need that sort of coordinator across the network. So it's useful, but yeah, whether those people exist is another matter.
Thank you, Pete. Eloise, do you want to come in?
Yeah, it sounds like an interesting role. I hadn't heard of it before. Is it on the list of approved roles for ARRS?
So I think, I mean, apologies, Hayley, and I always do this to you, but I think Hayley seems to be the only full-time cancer care coordinator, and I believe your job was a care coordinator job description. Is that right, Hayley? And it's sort of just been shaped really to fit the cancer agenda. Sorry to put you on the spot, but if you wanted to come in.
That's okay. Yeah, so I originally was employed as just a care coordinator, and then me and a clinical director, who unfortunately he's left now, we kind of molded it. So it's took kind of 2 years to get to this point, and it's really good though, because when I do attend kind of care coordinator meetings, I seem to be the only person that's actually got a fixed speciality. So that's, I don't get pulled to do anything else. I can just fully focus on being a cancer care coordinator, and I think I'm the only one when I go to kind of the nationwide cancer the care coordinator meetings. I think I'm the only person that does it full time. I haven't met another person yet that does my job role.
But
So I
I mean,
suppose
sorry, go on, Eloise.
So I suppose it's understanding what sort of population size and being able to, I suppose, map your workforce to the workload, but following it down a care coordinator line makes sense. Obviously, these roles are going to have to be employed by somebody who makes sense, so that probably fits.
Yeah. So have you've got care coordinators in your PCN though, Eloise, haven't you? Am I right? I haven't ever met any of them, but do any of them do any of the cancer work or?
No. Well, we wouldn't exclude them, but that's not their top focus. No.
So typically, the care coordinator is a receptionist. So it's the new name for the receptionist, and they're generally just directing the call
role to that.
So I think this is one of the things that we always discover when we start talking about this, is that they're kind of viewed differently in different PCNs, and there's also in some areas some of the social prescribers are picking up some of the cancer work as well. And I guess it doesn't necessarily have to be a full-time one individual, but I guess it's about that the role and what makes up that role, and having somebody who, or some people within a PCN who is responsible for those roles. That might be a more flexible way of looking at it. Pooja, sorry, I know you wanted to add a comment.
Hi, Kate. Yeah, thanks. I think, yeah, it'd be great, to have somebody in that role. We've actually got a non-clinical cancer champion, for the last couple of years, through some of our funds from the PMS schemes. But what she's mainly focused on is actually chasing up, the screening bit of things, and chronic non-attendees for cervical smears, socially deprived groups and things like that. But whether there would be a chance for her to progress into a care coordinator role with something kind of a bit more, like a navigation role as well into it, is what's made me think, with regards to this, and what would be her opportunities to kind of develop into this role if there is that there, But I think, yeah, it's a great idea if she could progress on this. Yeah.
Yeah, I think the navigation bit of it is really interesting, Pooja, because I know, Hayley, you sort of started to build relationships with the secondary care navigators, haven't you? And that can be quite useful as well. I mean, obviously, again, they work slightly differently depending on the trust, but I think all 3 trusts have now got navigators in place. So those links as well around individual patients can be really helpful. Sorry, Michelle, did you want to add something?
Yeah, it was just really sort of noting, I guess it's the definitions, isn't it, of a cancer care navigator. Absolutely. And that everyone's got a different view. But what I was going to do is there's the West Midlands Cancer Alliance have set up a primary care group. I think it's had its second meeting or about to have its second meeting. And
it's Thursday. It's Thursday, the meeting, yeah.
I think what we can do is sort of, I guess, note in particular, Hayley, your role, I know we all single you out, but just really to sort of see whether the Cancer Alliance have got any plans to expand that role, and if there's any sort of future funding streams that might follow, because absolutely wouldn't want to miss out on that. And I'm sure that the Cancer Alliance were quite keen to hear more about sort of the primary care cancer coordinator role that Hayley's in. So let's see how far we get there. And I think on that, and we could get some more information on sort of like generic job descriptions and an idea of what that role should be doing. And absolutely, if there are people in the system that we want to sort of, I guess, develop and progress on to the next step, then that's what we should be looking at.
Brilliant. Thank you, Michelle, and thank you everybody for those contributions. Okay, I'm just looking at the time and conscious that we're running out of time a little bit, so I'm just going to very briefly whiz through screening. And again, you know, there's a lot of information out there about cervical screening, but I can't put it all on a screen. But just to let you all know that the latest cervical screening data we have is Q4 from 21-22, so January to March of this year. So, you know, we have sort of data within the last 6 months. Again, the range is a huge variation in ranges. We run from about 47% uptake right through to 85%. But overall, as a CCG, apologies, we don't use that definition anymore, but obviously last year we did. So that's the latest data we have. We're at 68.1%, and that's for the 25 to 49 year age range. And when we're looking at the older age range, uptake is slightly higher at 75%. Just on the colposcopy, and again, I'm sure many of you are aware that there have been some issues, particularly with George Eliot, in significant delays in colposcopy waiting times. The NHS England are aware and are putting putting these in place to try and address those delays. As far as I can see, there are no sort of major delays in either of the other two trusts, so just kind of keep you up to date on that. Moving on to bowel screening. All of the Midlands providers have now rolled out the age extension for 56-year-olds. So the 56-year-olds are the individuals who would have been called up for the bowel scope, but that has now been phased out. So this age category are the first year to be involved in the age extension. And now the bowel screening centre have now gone live, and they're commencing the 58-year-old age cohort. So just to kind of be aware of that if you get any questions from patients around eligibility for the bowel screening programme. And I've just popped up some data. Again, this is slightly out of date because it's from fingertips, but it kind of gives you an idea of bowel screening uptake across the system. And England is around 66.8%. So you'll see, you know, everybody is sort of most PCNs are within those regions. Breast screening. So quite a major update really around the breast screening programme, and I know there's been lots of discussions at this group around capacity and delays and you know, difficulties getting through to the service, etc. We've been informed now as an ICB that the there's a typo there, the medical director of NHS England has raised concerns about our particular service because of delays with restoration. And you'll be aware that every time I update you, that date seems to keep jumping on, and again the service hasn't been fully restored by the date that they estimated, and it's now been moved to April 2023 24, apologies. So just to let you know that this has been escalated, and we've been contacted, and there's going to be some further meetings about that and how we can sort of address those issues. And just an update, as of the 4th of August, there were 2,110 patients with reporting a delay on invitation. I know there's also issues about location of breast screening. I know that, you know, that there's issues around where particularly the mobile unit can be placed. Please keep feeding back any issues that you have around that. I've been in contact with the Leamington PCNs recently because all of that is really useful intelligence when we're looking at the service as a whole. I'm just checking if there's any comments about that. Okay, and I mentioned targeted lung health checks. The phase 1 of the programme has come to an end in June. 34 practices have been involved to date, and that's 41,276 people have been invited, which is absolutely excellent. And the total number of scans that have been completed are 5,965, so significant numbers. Just looking at some of the data that's coming out of the programme, we're just about to start phase 2 of the programme. That was in Rugby, but it's just about to be relocated back to Coventry City Centre, and I've been in touch with some of you around your PCN starting the process. So I think Coventry North are signing up, and also Coventry Central and Go West, which is great news. And just some data for you. Really exciting to see that the majority of the cancers that are being diagnosed at stage 1, which is obviously the whole purpose of the programme. So that's really positive news. And you'll see that the other stages as well, and lots of incidental findings as well, but they are finding lots of lung cancers, which is a positive. Apologies, Michelle, I can see you've got your hand up, and I didn't know if it was regarding breast screening or targeted lung health checks. Do you want me to jump back to breast screening?
It was just around breast screening, just to say that there was a board discussion yesterday, so breast screening board discussion, and NHS England as commissioners have made it very clear that April 2023 is not acceptable. It's outside of the national recommendations. So it has really been escalated to a senior level, and there will be a focused conversation at the ICB Cancer Board on Friday, where we're waiting for some outcomes from internal discussion. So we will keep you posted in terms of what's happening and if there's any impact on your patients and your rounds as we get that information. Communication does seem to have been a sort of, I guess, let down really in this.
Yeah, thank you, Michelle. Okay, right, so handing over to Luke. Are you with us? Apologies, I haven't seen you. Are great. I couldn't see you on the list. I'll just hand over to you, and Lisa's going to come in at the end as well.
Yeah, sure. So since we last met, we've had the population screening timeline. I don't know if you've all seen that. It basically shows you right from ultrasounds in pregnancy all the way through to end of life scans. We've had that translated into 6 different languages, available to download from the ICB website. I assume these slides are going to get shared afterwards, so you'll be able to pick them up there. The cancer update letter hasn't been issued. It's just about to be issued, so you'll be getting one today. As soon as I've finished with this meeting, that'll go out. So if you don't receive it, or there's other people in your practices, please get in touch with Michelle and we can get you added to that distribution list. And then the final point on there is we are relaunching our patient forum for the system. So in terms of reference, is currently, it's been redrafted, so it's just awaiting the review and the approval of that, which can then be sent out with the papers to everybody in case there's any patients on your PPGs or any other cancer patients you know of who would be interested in sitting on that group.
Luke, can I just make a comment around the population screening timeline? It hasn't actually been sent out yet, just because I was sort of conscious of just sort of sending out comms without instructions. Just to make people aware, the population screening timeline is an NHS document which is basically everything you need to know about screening on one page. And I attended an event in Coventry recently. I think it was sort of at the beginning of the summer, and we had lots and lots of screening information which people didn't pick up. But the one thing that people really liked was this population screening timeline, probably because it's got everything they need on one page. And I know that sort of sending you a link is not that helpful. But just to say that, obviously you can have this digitally, but if people want, we can. Are we going to print any off, Luke? Is that an option, or is it just going to be available digitally?
Yeah, we could get them printed.
Okay.
There's plenty of printers available that would be able to get those printed in the different languages.
Brilliant. Okay, and I guess just thinking about AccuR text when you're making contact with patients about non-responders and that kind of thing, obviously this can be attached to text messages as well. I just wanted to add a bit of context behind that, and I'll be sending it out probably this week. I think you've got another page, Luke. There you go.
I think this was the holding slide.
You're on mute, Kate.
Oh, I'm on mute. Apologies, Luke. Can I hand over to you, Lisa?
Okay, so it was just a brief update, a couple of minutes on the Cancer Patient Experience Survey. So that's just been released this September, but it's data from 2021. It's always like a year behind. But the patient experience is supposed to be on a par with the clinical effectiveness and safety. And the integrated care systems had 1,116 patients respond out of a total of just over 2,000, with a response rate of 55%, which is in line with the national response rate. This year, the survey was slightly different because it included ethnicity and deprivation data. So there's more data in this year's survey. So you can't compare it like for like with the previous years, but it is quite useful to have this data so that we can sort of tailor our services more to what we've got in our area. Do you want to pop to the next slide? So there's just two slides on how we compare with the national picture, really. And I don't know if you can read it, it's not that clear, but the first one is, overall satisfaction with the service they've got is 8.92% nationally, but we in Coventry and Warwickshire scored 9, so we are above the national picture. And probably the other slide, the other comment that you would be interested on this slide is the support from your GP practice, and that the your referral for a cancer diagnosis was delivered to you in a way that you could understand, and that 63% was Coventry and Warwickshire, at 64% is the national average. I don't know if that's something that we could maybe focus on, possibly, because that's like nearly 40% of patients not feeling that they understand that they're on a cancer referral pathway. So that possibly is something that could be quite easy for us to work on, improve on next year, potentially. And then I won't go through all the other ones because you can have these slides. It's not that easy to read, but the next one, Kate, is care from your GP practice. And this is respondents about care that they had from their GP practice during their treatment. And I'm not sure this is a very fair question, really, because it's 46% we achieved opposed to 43. But I would say personally that cancer patients in the middle of their treatment are not particularly in touch with their GP practice. So I'm not sure that's a very helpful, that's my personal opinion, because it's after they've finished their treatment that we would want them to be in touch with their GPs and before. But living with and beyond, we've got 60%, 66% as opposed to 62 for patients understanding what signs to look out for. But I've just added in at the bottom this one, that patients that had a cancer care review by their GP in Coventry and Warwickshire was 18%, which is fairly low. And hopefully with the nurse training and in Coventry and Warwickshire that we're lucky to have somebody to provide the education to the nurses, because it's not a national thing, apart from the 6-month course that Macmillan do. The national average was also 18% for this, so we were the same as the national average, but I'm hoping that we could do something to improve on that. We've got questions, is it?
It's Pete.
Pete, sorry, Pete.
Yeah, I put something in the chat, but you probably didn't see it. It's because to increase those numbers, though, just having nurses do it doesn't always work, and if you haven't got the nurses trained, it doesn't work. So is there anything that's useful? Because we've got so many trainees that could easily do, and it's useful for their training to be knowing what they're doing with a cancer care review. Is there some resources that, rather than going on a training thing for, because there isn't only, it's for nurses. Is there something that's useful that we can train our trainees and other GPs so that it's nice and simple and get those cancer care reviews increased?
Yeah, I mean, I say there is an option with your nurses, but we could put on similar training for trainee GPs, and Kate and Hazel and I could definitely look at that. It's just that was the ask to start with the nurses, but I don't see why. I mean, I want to do cancer training for non-clinical people, clinical people. We want to respond to what the need is really. So I think if it's
absolutely, I think like I said, I agree, fine having your nursing thing, but so I've been doing all of ours in our practice with no training as such, and it turns into a nice general chat. And you know, these early 3-month ones, there isn't much you're involved with, and that's the thing, there isn't much. And like you said there, with all those other things, you know, it seemed to be just a bit of a chat, but going down the line is you know, the 12-month ones might be more useful. And if there could be something that's either put into the PLT or some more specific training for GPs and trainees, that would be very useful.
Okay, that's definitely something I think would be really useful. And not all practices want their nurses to do the cancer care reviews. The GP won't want to do them themselves. And I think, yeah, that's definitely something that we can look at doing as well, alongside doing the nurse training. Definitely.
Well, there's just been a suggestion in the chat that you could approach the VTS programme and maybe do an afternoon with them. They're always looking for new topics.
And what's the VTS? Sorry,
that's the trainee teaching every Thursday.
Oh yeah, because we have done some training on for cancer in that. Is that the ST1s and ST2s or not?
Yeah.
We have done some training for that, but but it wasn't necessarily about doing a cancer care review. It was more like screening and
NG12 we've done as well, early diagnosis.
Could be a second session.
Yeah, absolutely. Yeah.
You know, and showing them how to find the template, or even a screenshot of what it looks like.
And that's all, we do all that within the nurses course, but we could adapt that. We could definitely adapt it, no problem.
Got a couple more people wanting to comment. Lisa, Suzanne next.
Can I just ask, that patient who had a cancer care review by the GP, is that data that's pulled out externally alongside the patient filling in the questionnaire? Or is that the patient saying?
This is part of the questionnaire.
So is this the patient saying they've had a cancer care review?
Yeah.
Okay.
So it's the patients that fill in.
Yeah, I would say that figure is going to be entirely inaccurate, because I wouldn't say to a patient, right now I'm doing your cancer care review. I would have, as I think it was Pete said, a very general chat about it, but I wouldn't necessarily call it to them cancer care review, because it depends on the context you're discussing it in. So the 18% will be the percentage that perceive they've had it. It depends how the questions were.
But there's a lot with this national survey that you can dig into and say, a bit like the have you seen your GP during your treatment? No, probably not, but that's not unreasonable that you haven't seen your GP during your treatment. So yeah, there's a lot of ambiguity, but this is the first time I've seen them ask that question.
Yeah, I just think it's not going to represent how many cancer care reviews we're doing necessarily, because it's
and also this was 2020 and also this was 2021 when we were coming out of the pandemic, or still in part of it, so some of this date could be very different next year, just because of it. They'll be collecting the new lot of data for next year soon. So but I think generally when we are encouraging that when patients are invited for a cancer care review, that they do understand that they're coming for a cancer care review.
But when I don't necessarily invite them, I'll often ring them spontaneously. I don't send them an invite to book an appointment. I'll often just ring them. So I won't say, oh, I'm ringing you to do your cancer care review. I'll do it.
You ring them as an additional, like an extra on your list. Okay. I mean, we task and ask them to make an appointment.
It really varies. I mean, we've been a relatively small practice of 6,000 patients, we're now 11, so it's changing. But historically, we'd do a review of the new diagnoses in our what we call our vulnerable meeting and say, right, who's responsible for that patient, and then we'd each choose our own way of contacting them. But for me, it would be generally to spontaneously ring them, so won't give it a formal title. So
I would say by inviting a patient for a cancer care review, you are giving them the opportunity to think about what they want to bring up and what's bothering them, and that's the whole point of the cancer care review training, is looking at the holistic needs of the patient and what they want to bring to the review, what is worrying them, so they get time to prepare for it if they know that it's actually they're booking a review. That's an advantage of knowing that's what you're coming for.
To be fair, I think the way I do it works well. I don't disagree with you, but I don't think saying that because I ring spontaneously they don't get the option.
No.
I'll often be ringing them every couple of weeks if they've got any issues. They know that they can contact us. So, and
that's brilliant support to have a GP that offers that support to their patients, and I think that's fantastic. But that doesn't happen everywhere.
No, I just don't know that every practice will call it a cancer care review. That's all. I don't know what other practices do, but we don't. I don't know whether if other people do invite them in, they call it that. But then we also know that I just think 18% is going to be very underrepresented, because we all know what our figures are for cough and things like that, and it won't be 18% across the board.
And I say this is not data that's new now, is it? It's a year old.
I was just interested whether that data was pulled out separately or it was part of the
questionnaire. No, it's all part of the questionnaire.
Sorry, just Eloise has got a hand up as well. Lisa, Eloise, did you have a question?
I almost put my hand down because Suzanne just covered everything I was going to say, really. But you know, this is down to patients' perception.
Absolutely.
It's not down to reality. If you want to win the questionnaire game, then the solution would be to use more accurate, the standard Macmillan Flores before you're doing them. But if you set that against the quality of review that Suzanne's just described, then it just shows that what you're trying to do is win the questionnaire, not actually necessarily, well, arguable point, is it actually going to increase quality of care, or did you just prove that you sent the text message before you did the review?
Yeah, and it's a national survey that's had a lot of it criticised a lot, and it's we were just sharing what we had, and that was our Coventry and Warwickshire where we are.
Thank you, Lisa. Okay, I think we've come to an end. So yeah, we've got on to any other business. We haven't got any other business, but has anybody else got anything they wanted to raise? Can't see any hands.
I was just wondering, obviously with Hayley's position, I assume she's very busy, but what capacity she would have possibly if we identified people in our own practice that she could mentor, or at least give some tips to, might be something to consider.
I mean, do that at the moment.
Yeah, and I appreciate it's taken you 2 years to fine tune it. I'm sure there's other stuff you do as well. So we'd probably be interested if you have time to spare.
Yeah, I do. I have been helping a couple of other PCNs, so I'm happy to, if you do employ a care coordinator, I'm happy to meet up. I help them when reports and things like that. So yeah, it's fine. Just I'm happy to be sent emails. It's fine.
Oh, thank you, Hayley. Eloise?
Hi there. So I've been a bit busy, so apologies, I haven't replied to an email train that started earlier on in the summer. We were discussing the issue of GPs getting sent results that we didn't request, particularly thinking about histology, about endoscopy reports from 2-week waits that we've made. And, the request is basically that the GP is sent information about potential cancer diagnosis only at the point that the patient has had the diagnosis explained to them. I think that the current position is that while GPs want to know what's going on and we can get sent multiple copies of tests that we haven't requested, I remain concerned about that issue, because it is generating a huge amount of administrative burden and also mounts clinical risk in terms of patients having access to their records as of November, and being able to see that they've been diagnosed with a cancer before the clinician in the hospital has told them that they've got a diagnosis of cancer. The other thing is that from a GMC point of view, the person who's doing the requesting of the test is responsible for actioning the results. Even though the hospital isn't necessarily asking us to act on those results, if you're presented with the information, it takes a significant amount of time to process that, to check that it isn't actually something that you've requested, and also a lot of courage, particularly amongst more junior members, not to actually try and contact the patient and break the bad news. So, you know, I don't feel that that issue has been adequately addressed. So apologies, I haven't emailed about it, but I still think that it needs to remain on the agenda. And as I've demonstrated with those patient examples, it's had a massive, it often has a massive impact on clinicians and administrative staff as well.
So Eloise, I think that's happening across the board, not just on cancer. We get tons and tons of maternity stuff. I've started sending the BMA letter back to say that it's not our result. Unfortunately, I can't. It says I've called the departments as well, and the response we get is, oh, it's always been like this. But you're right, we haven't got time to log into CRS, and you know, you're in Nuneaton, aren't you? So again, I don't know if
we don't even get that.
Yeah, and I think it's a real serious issue that it's just putting a lot of workload onto us, and then we have to sort of fight with our own minds to decide what we should be doing next. Because if the patient doesn't know and they do contact us and we've got that information in front of us, it's, well, we don't always know all the answers to their questions they're asking. The only thing in terms of documents, we file in DocMan, it's not visible, the MDT proformas to them. There is a way of selecting what's visible and what's not. So if that helps, as a practice, you can decide what. So our DocMan people file that MDT proforma in a non-visible folder.
I think my request would be, I don't want any MDT information. Thank you very much. You know, what I do want is a letter from the consultant saying that these MDTs have occurred, this is what's been concluded, this is the diagnosis, this is what the patient has been informed, and making sure that we get that information in a timely way. Because I'm not saying we're not interested in the cancer journey, we absolutely want to be fully involved in that cancer journey, but it's making sure that you've got appropriate processes to mean that you are able to know the right thing at the right time in order to provide the right support for the patient. And I think that if their perception is that some GPs are asking for this data, I think really a deeper discussion about this needs to be had, because I think it's a simplistic view to say, oh yes, send us all the data, because actually it does cause harm, and you know, it's not an issue that when clinicians have entered into that discussion, then I find it very hard that people would reach the conclusion that they want to know about the 15 MDTs that have happened before finally the decision is made that the cancer has been diagnosed.
Thank you, Eloise. I'll bring in, I've got Naya and Pete as well to comment. Naya, I think you were first.
Yeah, just echoing Eloise's as well. We've had sort of a significant event in the practice for exactly those reasons, where we had information and it wasn't clear at all as to whether a diagnosis had been communicated. And again, one of our trainees had picked up the phone doing a cancer care review, ironically, a 3-month cancer care review, and the patient was completely unaware of the results and the histology that hadn't been communicated. So a lot of backtracking, you know, a lot of, you know, patient distress with that really. But again, sort of the learning from that was obviously, you know, it's good to be involved, but it needs to be that the way the MDTs are being communicated with us needs to be in a summary letter from the consultant to kind of look at what the upshot of that has been, and actually real kind of clear communication as to, you know, what the patient involvement throughout that has been really, and then where we step in as GPs. I think it's nice to be involved. I mean, I tend to do all the cancer meetings in our practice, so it's quite nice to have the story so far, but I don't need 10 MDT updates. I can have that in one letter, and actually, and that's just as good. I don't need histology reports or anything like that really, but yeah, we've had one quite significant, well, it was significant, but quite a serious significant event really. So there is definitely harm that potentially comes from this.
Pete, do you want to add anything?
Just fully agree, much the same, and I've fed it back before, but the problems you get as well, it's also a coding issue that you get that MDT and a coder's gone and coded a cancer. I've gone back in and removed it until it's actually been confirmed, and you're then, you know, a month into your pathway or something of the cancer care review, and you might miss it because then the person's been coded as cancer when they've not even been told they've got cancer. It's not been confirmed. So I find a lot of issues with those MDTs, and I know our secretaries do block access then to records when that comes in, as I've asked them to. But you're right, Eloise, if it's not even there, that's the better solution. We should only really be coding or starting their cancer journey once they've had that diagnosis with a consultant. We've got a letter that's got a confirmed diagnosis, stage, you know, TMN, whatever, because you need all that information. You don't need every MDT meeting. 100%.
You want to know the intent of treatment and whether it's palliative or curative. That's the sort of information you want. It's a treatment summary, really. That's what it is, and that's.
Yeah. You want the consultant, which is either the specialist or of that area, or the oncologist, whoever they've seen when they've got that diagnosis. That's what we want to know. We don't need the MDT. It doesn't help us. It complicates things.
Michelle, do you want to come in?
Yeah, it was just to say, I think all what you've all reported, Hazel had already picked up, and I'm pretty sure that, I mean, obviously it's a bigger issue, isn't it, than just cancer patients, as someone pointed out. I think what we need to do, Kate, is probably have a chat with Hazel and also backtrack on where she left things, because I'm pretty sure that she raised all of the concerns with the digital lead within the system, who's got a much broader knowledge of this. So let's try and pick that up and just sort of get a position statement. From memory, I thought that the message was we can't do anything until. And there's something coming in which I'm not quite sure. I can't remember the technicalities around that. So if you can just bear with us, we'll get a position statement on that.
That's right, Michelle.
She was doing stuff like
she was, and I met with George Elliott on behalf of Eloise with this very issue, and I can say to this group, they pushed it straight back again, which is what I communicated to Eloise, which is obviously hearing everybody's concerns today has made me realise that that's not an acceptable, you know, their answer was no, this is the way it is, and we're going to continue to share all of that information. So, you know, hearing what everybody's had to say today, I think we need to go back again. And it's not just George Elliott, it's Swift, and it's also UH as well, because that's an example from each of our trusts. I'm not quite sure who we go to, Michelle.
It's Alec and Simon Jones, Alec Price Forbes and Simon Jones. Yeah, we'll pick it up outside, Kate. I'm happy to support.
Okay, I hope that's okay, Eloise. And obviously the other GPs that have commented today, we will sort of keep pushing with this. And thank you for your feedback.
I think it's like a historic thing, isn't it? When the MDT coordinators came into post years and years ago, it was an automatically send the GP a copy of it.
Okay, I think I'm sorry, we've got to 2 o'clock. Apologies that we've run over slightly, but I think that was a really useful discussion. Thank you everybody again for your really helpful contributions and sharing everything that you're doing. You know, we really value the feedback. The meeting's been recorded, but we will send out the slides and also the action notes. And I know there's a number of actions, particularly FIT. I think that's the one that I've taken today that we need a lot more information on. But you know, myself, Lisa, are always at the end of an email. If you've got any queries, please continue to send your questions, queries to us, and we will respond the best we can. Okay, our next meeting is, I believe, December. Yeah, so Tuesday, the 6th of December, same time, and obviously that should be in your diary, but you'll get all of the correspondence related to that nearer the time. I think that's it from me. Thank you very much, everybody, and I will see you all soon.
Thanks, Kate.